class එකක් තියෙනවා උදේට wardrobe
හැමදාම class එකක් තියෙනවා sir 11:30 12:30 class එකක් තියෙනවා sir schedule කරලා හැමදාම.
ඒතර සමහරද හවස එක මොකද්ද කහමාර එක?
හවස එකහමාරට ඒ කියන්නේ ward work තමයි තියෙන හවස sir.
ක්ලාස් එකක් නැහැ. සමහර දවස්වලට ක්ලාස් එකක් තියෙනවා.
අද 11 තියෙන ක්ලාස් එක තමයි එකහමාරට shift උනේ sir.
හරි. එතකොට දැන් කවුද ward rounds කරන්නේ?
මේල් බෝඩ් එකේ චෑන්ක්ස් වෙනුයි කන්ස්ටන්ට්ස් වෙනුයි. ෆීමේල් බෝඩ් එකේ ෆීමේල් බෝඩ් එකේ සර් මං හිතන්නේ
කමනේ අවුලන්නේ. මේ රයිට්. එතකොට තාබෝල් එක්සෑම් තියෙන කා දවසක් කිව්වේ නැහැ නේද හරියට?
March 21st වගේ තමයි සර් පේපර් එක තියෙන්නේ මම හිතන්නේ.
ක්ලිනිකල්ස් ගැන තාම කිව්වේ නැහැ නේ. ඒක කලින් තියෙන්නේ.
ඒක කිව්වේ නැහැ සර්. ඒක නෑ කිව්වේ නැහැ.
රයිට්. තව කට්ටිය නිදිද දන්නේ මේ වෙලාවේ ෂේප් නේද? කරදරයක් නැහැ නේ.
ප්‍රශ්නයක් නැහැ සර්. අවුලක් නැහැ.
Yeah. Welcome to Prof Medicine. Right. So the basic idea of the sort of sessions that I'm going to do are going to focus almost 100% on exam preparation. Okay. It's not going to be how to become a good house officer and how to develop your clinical sense and that sort of thing. You will have classes or sort of focusing on that, but my basic idea is to focus on the exam. Okay. And in order to do this, obviously now you have 8 weeks, of which the last week is an assessment week. So the focus that we're going to do first is we're going to finish off all the long cases and then do a few sessions on short cases. The problem is obviously I can't do short cases like I usually do, obviously for obvious reasons, but at least to sort of go through some of the common short cases and how you would present and how you would sort of analyze and discuss, we will do. But the important thing is try to, I'll tell, Gitmi is your SR now, isn't she? Hiru SR la kawuda Gitmi ne dinne? Aluten kawuth aave nahe තාම? Hello. ළමයි
hello sir.
මේ SR කවුද ඉන්නේ? ගිත්මි දින්නේ?
sir මට නම ෂුවර් නෑ sir තාම.
බෝලයක් වගේ ටික හයියෙන් කතා කරන පිස්සු වගේ කෙනෙක් දින්නේ.
චුට්ටක් ඔව් ඒ වගේ කෙනෙක් ඉන්නවා sir.
කියන්න මම කිව්වා කියලා මම මෙහෙට ඇවිල්ලා මරාගෙන කයි. හරි. ගිත්මිට මම කියන්නම් පොඩ්ඩක් මොන හරි ඕගනයිස් කරන්න කියලා. හර්ෂ ඉන්නවද මේ දවස්වල? ෂෝට් අපොයින්ට්මන්ට්ස් හර්ෂ?
හර්ෂ sir නෑ sir මං හිතන්නේ.
නෑ නේද? So that we can get some short case sessions. What I used to do was when I was in Sri Lanka, we used to sort of split the group up into a few groups and take you around cardiology, cardiothoracic, neurology, and so on. We'll try to get that organized. Obviously, for obvious reasons, I can't do that from the UK. And then, so we'll do the long cases first. Then I'll do some short case discussions. But in order for you to practice your physical science and examination technique, we'll get some of the people to take you around. We have a new set of registrars. We can get their help as well. Maybe the senior people, not the new ones. Then the other thing that we will do is obviously for your end of appointment assessment, you will have an emergency viva and an OSCE. So we'll do some sessions for that as well. Okay. And that is basically it. Right. So we start off with the long cases. Now, general rule for the long cases is that I'm going to follow a format where now before you started professorials, I did some classes for you. And this was on how to take a history, how to interpret physical science. And then we did a few case histories where we talked about how to take a history, how to analyze a particular symptom and so on. So please don't, I hope you're not thrown all those lectures away. You should have recordings of those. So it's important to listen to those in your first week again to focus on that, because I won't be revisiting that in that depth again. What I'm going to do in the long case discussions is going to be more of a question answer. So obviously, I'm not going to question the person who's presenting, so don't worry. So I'm going to sort of see what are the questions they would like to ask, what are the questions they would ask you at your exam, and they will try to build up an answer for that based on the case that you present. And I'm not really going to go into symptom analysis and all of that I did before, so please revise that. So we're going to do focus more on exam, what they would ask, what the question they would ask, what the answer you would give, and sort of go on a question and answer basis because you're preparing for your exam. But in the first week, it's important to sort of revisit the teaching that we did before you started professorials. And for all the cases that you present, නිදා ගන්න නම් එපා පුතා මට පේන්නේ නැහැ උඹලා මොනවද කරනවද කියලා. So don't sleep, but try to sort of write down a summary of the case history and examination, everybody, while we are presenting. And then we'll go on and discuss the questions. Amila, okay, so we can start.
So my patient is Mr. Jayatilaka, who is a 54 years old patient from Kitulgala. He's a father of 4 children and he's working in a bakery. And he was recently treated for prolonged fever and patient was on anti-TB medications, and this time presented with recurrence of previous symptoms of generalized malaise, loss of appetite, and fever for 5 days duration. Because the symptoms, this time symptoms have a strong relationship for the previous episode, I will start with that.
Okay.
1.5 months back, patient was apparently well. He gradually developed fever, which was initially low grade and progressed into high grade fever within 2 to 3 days.
Okay.
Fever was intermittent with 2 to 3 spikes per day, and also there was associated chills and rigors with associated frontal headache also. In between fever episode, patient was well. There was also night sweats and generalized malaise noted by the patient. And due to unresolving nature of the fever, patient admitted to the Kitulgala hospital after 3 days of symptom onset. And their blood count was taken, and because of the abnormality of the cell count, he was transferred to the Karnamalla hospital. There he was Karnamalla hospital. There he was treated for 19 days. 19 days. Fever was continued throughout the hospital stay with 1 to 2 spikes per day. Also, he developed several vomiting episodes and arthralgia and myalgia with associated loss of appetite and loss of weight towards the end of the course. He lost 6 kilograms from his initial body weight of 66 kilograms, which was 9% weight loss during the 3 weeks of duration.
Okay.
There was no associated history of chronic cough, hemoptysis, or shortness of breath during the episodes, and there was no contact history of TB. Also, patient doesn't complain about feeling of any neck, axillary, or inguinal lump. Before the episode, patient didn't have recurrent infection or bleeding manifestation. Also, there was no past history of valvular or congenital heart disease or any cardiac surgery procedures done. Also, he didn't had any alteration of bowel habits or significant travel history. And there is no oral ulcers or alopecia, and there was no high-risk sexual exposure or blood transfusion done to the patient. During the course of the illness, he didn't develop any rashes, loose stool, dysuria, and patient was previously well that he had no drug history prior to the illness. During the hospital stay, he was done several blood, urine investigation, and sputum analysis, and marker tests, and X-rays and ultrasound scan, and treated with IV medication, but the patient doesn't know about the medication. Then after 19 days of hospital stay, he was transferred to the NHSL. In the NHSL also, fever persists and extensively investigated, and patient was started with anti-TB medications. Fever was controlled and he was discharged after 5 days of hospital stay. He was advised to maintain a fever chart at home. After discharge from the hospital, for about a week, patient was well, and he again started to develop generalized malaise with reduction of day-to-day activities and loss of appetite and loss of weight, with gradual onset several episodes of fever spikes, which were low grade and intermittent from second weeks onwards.
Right.
There was no associated retroviral pain, arthralgia, myalgia, loose stools, dysuria, or any respiratory symptom during these fever episodes. And also, there is no history of discolored body fluids, rash, or blurring of vision.
Right. Amila, just to interrupt you there, just a general point for everybody listening. When you have a set of series of negative symptoms, now Amila has done a very good job in giving us a beautiful timeline of this patient's presentation. But now you're talking about again a short sort of fever for 5 days. You don't really have to talk about all the negative symptoms. You can say he had fever and there were no other symptoms of relevance or no other symptoms of significance. You can just say that, otherwise it becomes a bit boring to listen to. Okay, so for all of you, when you have a lot of negative symptoms, you don't really have to talk about everything and say he didn't have chest pain, headache, or whatever. You can just say that the patient did not have any other symptoms of significance. Yeah. Okay. Right. You can continue, Amila.
Current patient is treated with anti-TB medications and antipyretics and waiting for CCT abdomen, pelvis and chest and bone marrow biopsy.
Okay. Right. Just a small question for my my thinking before we move on.
Doesn't have any.
Amila, do we know on what basis this guy was started on anti-TB? Is he aware about that? On what basis he was started on anti-TB? Did anybody tell him that he had a positive sputum or something like that? Or was it they ran out of options probably and gave him?
No, sir. There was done a HRCT and their miliary tuberculosis was identified.
And that was why they put him on anti-TB.
Yes, FBN gene expert was done. It was negative.
Negative. Okay, just on the CT appearance. Okay, fine. Okay, yeah, continue. I mean, you can continue.
He is a father of 4 children, and he's working in a bakery. And there are 2 sons and 2 daughters. His wife is a housewife. All children are married, and there is no recent history of fever. There is no history of malignancy in the family.
Right. Okay.
He's a chronic alcoholic who takes about 1 to 2, who takes about a quarter of a bottle for about 1 to 2 times per week, and also used smoke 3 to 4 cigarettes per day, about for 20 years. And sometimes he use illicit alcohol 2 to 3 times per week. And other than that, no other substance use.
Right. I mean, again, a small comment there. Don't use the word chronic alcoholic. People don't like that term. Talking about alcohol, everybody, again, these are very, very important tips for your long case. Don't use those words. You can actually piss some examiners off. So you have to quantify or qualify the diagnosis. So you can say alcohol dependence, for example. Have you done psychiatry, by the way?
Yes, sir, we did.
Yes, sir.
Yeah, so in psychiatry, they would have given you a list of various diagnoses for alcohol use. So use those standard terms. Don't use words like chronic alcoholic. Yeah. Yeah. Okay, continue.
There's no contact history of TB in the society, and also there was no recent relationship with the foreigners with the patient. And their nearest hospital is Kitulgala, which takes about 5 to 10 minutes to go there.
Okay.
His monthly income prior to the illness was 60,000 per month, and currently having no economical problems. He lives in a rural area, and there was no contact history of TB in the village also. On examination, His weight was 60 and height was 175, which means
Just tell me
BMI.
the significant findings only, Amira.
He's having a mild pallor,
Mm.
and in the abdominal examination, he's having hepatomegaly, which is 2 finger breadth from mid-clavicle line, regular margin and smooth surface, and also 2 centimeters having splenomegaly, which is also 2 centimeters from the mid-clavicle line, which is firm, regular margin with smooth surface.
Okay. Anything else?
Other system examination was normal, sir.
Okay. Right. Did
There's
you have a
no
look at the
lymphadenopathy
fundus?
also.
Did you have a look at the fundus?
Yes, sir. There's no papillary.
Nothing.
No, sir.
No significant findings. Okay. Could you summarize your history and examination for us, please? So that is usually the first thing that the examiners ask you after a long history. And Amil has done a very good job of sort of giving us a very nice chronological presentation. And I think all of you should sort of learn from that as well. And a very beautiful history. So a few things that I pointed out, don't use terms loosely, and you can get penalized for that at the exam. And another thing, don't use words like mild pallor. It doesn't make any sense. Either you're pale or not, right? So don't use things like that as well. So be professional in your presentation, use accepted terms, and you will do very well. So apart from that, the history was very good. Could you summarize your history and examination, Amila? So that's the first thing that the examiner will ask you to do. Yeah.
54 years old male from Kitulgala admitted due to generalized malaise, loss of appetite, and fever for 5 days duration. He's been on treatment for tuberculosis with anti-TB medication after investigated for prolonged fever for 4 weeks duration. Current symptoms are similar to previous episodes, and currently patients having occasional fever spikes, which is high grade with associated loss of appetite and generalized malaise.
Okay.
On examination, he's pale with hepatomegaly and splenomegaly. Currently treated with anti-TB medications.
But no lymphadenopathy.
Non-lymphadenopathy. Currently treated with anti-TB medications and awaiting for CCT, abdomitis.
Yeah, you don't really have to mention that. You don't have to mention that. Don't worry about that. Okay, so we'll work on the summaries later. And as we go on, I'll give you more inputs on how to present a good summary. But that was generally acceptable, so there was no major problem there. Right. Okay. So the first long case that we are talking about is a patient with prolonged fever. Okay. And just to give a little bit of background knowledge that you need to know when you get a long case of PU, and all of you should prepare for a long case of PUO. It's one of the very sort of famous favorite long cases that we select for the exam. Okay. So you're definitely going to get one of them. A few of you will get a case of pyrexia of unknown origin or prolonged fever. So one thing that you always need to know, and somebody might ask you, is what the definition of pyrexia of unknown origin is. Just to revise what we've done before you started professorials, I did a class on PU, I think. So just to revise that, remember that pyrexia of unknown origin is defined based on the setting in which it occurs. Okay, that is the first important thing that you will say. If somebody asks you, some of these really old clinicians like to ask you definitions. There are some people, I won't name them, but you might be able to guess. So they ask you for definitions. So you should know that if somebody asks you for a definition of pyrexia of unknown origin, the first thing that you say is pyrexia of unknown origin is defined based on the setting in which it occurs. And therefore, you have a classical pyrexia of unknown origin, or in other words, community-acquired pyrexia of unknown origin, where the patient is in the community, is an otherwise healthy fellow who comes with fever of unknown origin. Then number two, you have PUO in hospitalized patients. Okay, PUO in hospitalized patients. Then you have PUO in the immunocompromised. PUO in the immunocompromised. And a subgroup of that is patients with HIV. Okay, so people who are immunocompromised, and obviously PUO in HIV would be an important subcategory of that group. Right. And also within that group of immunocompromised PUOs. You have PUO in neutropenic patients. It's slightly different approach as well. Right. Fine. And obviously, you have PUO in travelers, which is an important category as well. Okay. Even in Sri Lanka, this is an important category, PUO in travelers. So remember that PUO is defined based on the setting in which it occurs. So if your patient is from the community, a perfectly healthy guy who comes with prolonged fever and without a focus, Pyrexia of unknown origin from the community. And you have PO in hospitalized patients, PO in immunocompromised that includes HIV and neutropenic patients, and PO in travelers. So these are your broad categories of pyrexia of unknown origin. But for us, we generally deal with PUO from the community, and that's what medical students are expected to know how to address. And obviously, the definition is to qualify for PUO, you have to have fever for more than 3 weeks. Okay. And a focus or diagnosis is not reached. Okay. Despite rational investigations, either as an inpatient or as an outpatient. Okay. Right. There are timelines for this, right, which are actually changing. The standard old age definition was 1 week of inpatient investigations or 3 consecutive outpatient visits. But that's changing, and people are changing that because of advances in medical technology. Okay. And we should be able to reach a diagnosis quicker with all the stuff that's available to us now. Okay. But in general, to qualify for a diagnosis of PUO, fever for more than 3 weeks, where a diagnosis is not reached or a focus is not found despite rational investigations, either as an inpatient or as an outpatient. Inpatient, we generally say 7 days, outpatient on 3 visits, but that's less important now because we have much more facilities now and we should be able to diagnose them quicker. So these timelines are getting shorter and shorter. So that in general is your definition of PUO. Right. Now, if you take community-acquired PUO, it's further divided based on cause into subcategories, where you have infection, inflammatory disease, neoplastic disease, and a group of things called other. Right. Miscellaneous is another big word that we use for that. So you have community-acquired PUO due to, number one, infection, could be due to an inflammatory, autoimmune, sort of connective tissue vasculitis sort of thing. It could be due to a malignancy, a neoplasm, okay? Or it could be due to a set of miscellaneous causes, where the miscellaneous causes you run into hundreds and hundreds of things, which you don't need to know very much about. Right. And part of your workup is to try to figure out what exactly the diagnosis is. And Amila has done a very good job of addressing all of these components very well. Before we move on to the questions that you would get asked in this particular patient, the first thing is that you need to, obviously, in all patients with PUO, take a travel history, detailed travel history. That's something that we expect you to do. The second thing is you have to take a sexual history, right? That is very, very important, right? So make sure that you take those 2 things. Right. So that discussion was on preliminaries, a bit of background to this long case. You need to know the definition of PUO in a rough sense, right? And because it's changing. And you also need to know a little bit about the various categories of PUO. And within the category of community-acquired or classical pyrexia of unknown origin, the subdivision was infection, inflammation, autoimmune connective tissue disease, neoplastic malignancies, example, and then the miscellaneous group of things. One of the important miscellaneous ones are thyrotoxicosis, right, which sometimes presents with fever, and you thyrotoxicosis. Fine. Right. Okay. Now, the first thing that they will ask you in this case, after obviously you take a little bit of time to present this history and examination, you just discard this TB diagnosis, okay? And basically, you have a patient with PUO obviously fitting into the diagnosis quite well, PUO, with loss of appetite, loss of weight, and hepatosplenomegaly. So if you to summarize this patient in one sentence, it would be pyrexia of unknown origin, okay, with loss of appetite and loss of weight, with hepatosplenomegaly. That is, in summary, what this patient has. Okay, summary what this patient has. The first thing they would ask you is, what is your differential diagnosis of this patient's pyrexia of unknown origin? So that is the first question. So the long case would be going on. They would ask you, present your summary, which we have done. Amila has done that. They might ask you, what is PUO? What is the definition of PUO? And what are the categories and causes of PUO? That might be asked. But focusing on this case at hand, the first question they would ask you specifically about this case would be, what is your differential diagnosis? And the beautiful way to answer this is, this patient has pyrexia of unknown origin with loss of appetite and loss of weight. He's from the community and has hepatosplenomegaly on examination. So what is your differential diagnosis for this patient? PUO, loss of appetite, loss of weight, hepatosplenomegaly, guy from the community without any medical comorbidities. So always remember to have a list of 3 to 5 differential diagnoses, right? Not more than 5, nothing less than 3. So that is a general rule that as an examiner, we always tell our medical students to have a 3 to 5 list of differential diagnoses. So what would be your 1, 2, 3 in this patient? Obviously, disseminated tuberculosis would be one of them. Okay? Disseminated tuberculosis would be one of them. And very, very obviously, they're present with PUO, hepatosplenomegaly, and loss of appetite and loss of weight. Loss of appetite and loss of weight are always seen in TB. You would never get TB without loss of appetite and loss of weight. So that is something that you need to. Your first differential diagnosis should be disseminated tuberculosis, right? This is a classical presentation of it. Right. What would you list as your second differential diagnosis? I would say HIV with an opportunistic infection. Okay, HIV and AIDS, which are opportunistic infection, would be another very, very important differential diagnosis. I can't remember Amila talking about this guy's sexual history, sexual contacts, but that's a key thing in this history. And even the patient completely denies anything, you still have to consider HIV, AIDS with a second sort of superadded infection, right? Now, this superadded infection can be TB, and that is very, very common, but can also be a list of other exotic organisms which you need to just read about and learn about. Okay, exotic list of organisms, including various types of mycobacteria, which are non-TB mycobacteria, okay, and various other viruses like cytomegalovirus, for example, okay, and odd fungal infections, and parasitic infections. So very, very odd opportunistic infections which can occur in HIV, AIDS, and these are opportunistic infections. They don't cause infection in people who are immunocompetent, but they do cause infection in patients who are immunocompromised. So that would be your second differential diagnosis. Third differential diagnosis, I would say, is lymphoma, even though the patient does not have any lymphadenopathy. Okay, so lymphoma, again, PUO, can present identical to TB, right? And they come with loss of appetite, loss of weight. And remember, the fever that occurs in TB and in lymphoma, which we classically describe, is nocturnal fever with drenching night sweats. Evening to night fevers with drenching night sweats are very sort of well described in both TB and in lymphoma. Okay, so lymphoma is another very, very important differential diagnosis in this particular patient. Right. Okay, so if you were to talk about your top 3 differential diagnoses, these are your top 3 differential diagnoses. So that's the first question they would ask you. What is your differential diagnosis? And you would list out these differential diagnoses: disseminated tuberculosis, HIV with opportunistic infection, in the state of AIDS, that is obviously, you know the definitions of that, right? And that could be due to a whole range of exotic bacteria, viruses, parasites, and fungi. And then finally, you could think of lymphoma as your third differential diagnosis. Now, always, if you're pressed for more, don't commit yourself, but always keep your mind open. Could this be some other infection, right? Some other infection, melioidosis being quite common these days, which cause hepatosplenomegaly and cause PUO, okay? Melioidosis. What's this guy's occupation, Amila? I can't remember what his occupation was.
He's working in a bakery.
Okay, so he doesn't have any contact with soil or hasn't been farming or gardening or anything like that.
No.
Okay, but remember, keep that in the pitch, and that's something we routinely test for nowadays as well. And it can cause PUO, loss of appetite, loss of weight, organomegaly. The other thing to be always careful of is make sure that you're not missing an autoimmune syndrome, right? Remember, autoimmune syndromes can also cause a hepatosplenomegaly as well, right? And autoimmune syndromes, and one of the famous ones that we often miss is Still's disease, okay? But of course, Still's disease, you would have prominent joint pain and rash, okay? Prominent joint pain and rash, right? So these are some of the things that you need to consider if you're pressed for more. But I would stick to the top three. Would be disseminated TB for obvious reasons. It's a very classical presentation of it. The second thing I would say is HIV/AIDS with opportunistic infection, and I would also put lymphoma in the mix as well. If you're pressed for more, consider things like melioidosis. Also consider whether you're missing out on an autoimmune, which seems less likely because the patient does not have any joint pain or rashes or anything to suggest an autoimmune type syndrome. The other cases that crop up very frequently are infective endocarditis, which appear very frequently in the exam, right? But obviously they would get a murmur as well. And this has been going on for months and months. I would expect to have some sort of heart failure by now if they had endocarditis. Then you didn't find a murmur as well on the exam, so it becomes less likely. Somebody asks you, couldn't this be endocarditis? They ask you at the exam. And you say, endocarditis, you have to be very careful when you're answering. Endocarditis does cause PUO, but I didn't find a murmur, and the patient doesn't have any obvious risk factors for endocarditis, right? Like intravenous drug use, for example, and you didn't find a murmur. Patient didn't have any cardiac history. So you have to defend yourself saying, no, it couldn't be that. But that comes up very frequently in the exam and as a PUO case. So you need to know how to work that out as well. Typhus is another thing that appears in exams. But remember, typhus, again, PUO with a rash is the typical presentation of typhus. And lymphadenopathy is very common. Okay, lymphadenopathy is very, very common in typhus. Okay. And obviously, you might see this Eshka, which I've seen only once or twice, but you might see that. But those are other cases that crop up. I wouldn't give those a differential diagnosis for this particular patient. Okay. A word of caution is that you love to say typhoid fever as a differential diagnosis of PUO. Please don't say that for any fevers beyond 2.5 weeks, because that's not possible. Either they die or they sort of recover spontaneously. Typhoid fever would never go on for months and months. I'm telling you this because you love to blurt that out at the exam. Please don't do that, especially in this patient. It's not possible. Okay, so that's what we have been doing. So you show for your discussion in this long case, definition of PUO, coming on with a list of differential diagnosis, giving a nice summary of a one-line summary of this patient's problem would be what we would look for and give you marks for. Okay. If you're pressed for further differential diagnosis, you can talk about melioidosis, you can talk about undiagnosed or something like connective tissue disease, but that's less likely given the clinical profile, no rash, no joint pain, no oral ulcers or hair loss or anything to suggest that at the moment. Okay. And if they ask you directly, could this be endocarditis? I would say it's less likely given the clinical presentation and what we've discussed in the summary as well. Yeah. Fine. Okay. So that's what they would ask you, right? Now, the next thing they would ask you, next question is, ignore this TB diagnosis. If you were investigating this patient for the first time, how would you establish a diagnosis? How would you establish a diagnosis? That's the next question you would get asked. So I hope that you're writing these down and making a note of this. And before you go for the exam, you're going to read these set of notes. We're going to do about 15 long cases during these 8 weeks. And that's all you study on the last day, nothing else. And you're definitely going to get through the exam if you do that. And this is tried and tested for more than, how long is it now? Yeah, for more than about 10 years, it's been tried and tested. So nothing to worry about. Okay, fine. So how would you investigate this patient to establish your diagnosis? Now remember, any PUO patient, you would do a set of basic investigations, right? Now just don't blurt that out and say, I do basic investigation. That doesn't mean anything. All PUO patients should have a full blood count. They should have a blood film. Okay, they should have a full blood count. They should have a blood film, right? And they should have so full blood count, blood film, and obviously inflammatory markers. Okay, full blood count, blood film, and inflammatory markers. ESR and CRP, which can be quite useful, especially if thinking like something like SLE, where you'll find the ESR high but the CRP normal. But you generally, these are the basic baseline investigations: the full blood count, blood picture, and obviously inflammatory ESR, CRP. You would also take a set of blood cultures in all your patients, right? Take a set of blood cultures. They're probably going to be negative, but you might be surprised as to what you would grow in these sometimes, right? So send off a set of blood cultures in all your patients with PUO, right? Okay, so these are your baseline investigations. And also say that you would do liver functions and renal functions as a baseline as well, which are important for you to plan out management and things, right? Right. Okay. I forgot the urine FR, which is again a basic investigation for any patient with prolonged fever. Okay. So blood cultures, urine, and your full blood count, blood picture, and inflammation markers. These are baseline investigations for everybody with PUO. Fine. Then we now focus a little bit more on our differential diagnosis. So we included tuberculosis in our differential diagnosis. Oh, before we go there, Amila, do you have a record of his blood investigations when he first came in? His full blood count, ESR, CRP, blood cultures, and things that we've been talking about now. Do we have any of those available? So it'd be nice to discuss them as well. And you do this at the exam. You give them, we give you the reports and write, what do you think about this? And ask you questions on them. So Amila, do you have access to that now?
I have several investigations.
Yeah, I would like sort of the full blood count on admission, the previous admission if possible. The first
previous admission full blood count was not there.
Okay.
Only sputums, AFB and sputum gene experts.
Right.
Specific investigation.
Right, that's fine. What is his full blood count showing now? Might be altered because
now, sir,
things are going on.
WBC is 6.03, neutrophil 71%, lymphocyte 14, hemoglobin 12.4, platelet is dropping, sir, 52, suspecting due to anti-TB treatment.
Yeah, it's probably due to anti-TB. Yeah. Okay, that's fine. So nothing much there, but remember that pancytopenia is a very common thing that occurs in disseminated TB. Okay, so you need to look out for that. Right, so how would you specifically now work this patient up? You got a diagnosis of TB in the background or a differential diagnosis of TB. So what would you do? You would list out these very quickly without thinking. So chest X-ray is obviously very, very important. Sputum for acid-fast bacilli and culture. Gene expert is an additional thing that you can do, which is a PCR test. So send off a sputum, do a chest X-ray. That is essential. The MAN2 test is less useful in a diagnosis of TB, as you all know. But if it's very, very strongly positive, then you need to consider that this patient has active TB. So if somebody asks you to do a MAN2 in this patient, you can sort of put it either way. You can say that MAN2 is sort of, it's more latent TB, and that just the fact that you've been exposed to TB before that it represents. But if it's very positive and ulcerating and so on, it might point you in the right direction, right? But it's not a diagnostic gold standard test for active TB. Remember that, and tell that to the examiner if they ask you. Right. So yeah, so you do your basic stuff. You get the chest X-ray off, get the sputum off, get a chest X-ray done, send for gene expert, consider doing a MAN2. Most of the time we end up doing it ultimately. And then probably from this patient, whatever the sense is that the chest X-ray was a bit abnormal, and they did a CT scan and they thought it was miliary tuberculosis, and hence the diagnosis of TB and the treatment for TB as well. Probably I would assume that that is the case. Sometimes when you don't find anything and you still want to think of TB, we do bone marrow aspirations and send that off for TB culture. And sometimes we've had a few positives of that as well. So yeah, so the last resort is get a bone marrow off for TB. That's the last thing that you would do for a TB diagnosis, right? For HIV, obviously you'd send the HIV test, right? Talk to the patient about it before you send it. We do test quite frequently for HIV now, and the primary reason for that is not only to make a diagnosis in this sort of patient, but if you diagnose it early, it's completely curable now with all the medication we have now. So that's very important. And asymptomatic treatment has made a world of a difference in HIV management. So yes, HIV test, send that off. And now we have a very good fourth generation HIV test, which combines, I taught you this, I think, combines the rapid diagnostic with the antibody and the antigen test in one kit, which gives you a very quick test, and the window period is very short as well. Fine. So do that. And then for lymphoma, the diagnosis, remember lymphoma is diagnosed based on tissue diagnosis. So you need to do a CT scan, chest, abdomen, pelvis, and then if there are lymph nodes, you need to biopsy those lymph nodes. And lymphoma is diagnosed solely, purely on lymph node histology, right? Not on LDH. So LDH is useless to diagnose lymphoma. Yeah, it's a non-specific marker that gets elevated in almost everything. So lymphoma, your thing would be CT, first ultrasound, obviously, but then CT, chest, abdomen, pelvis. If there are lymph nodes, biopsy those lymph nodes, and that will give you the diagnosis of lymphoma. For melioidosis, obviously blood cultures, antibodies for melioidosis are the two investigations that you would do, right? And if you're thinking of autoimmune thing, do the ANA, complement, and see. In Still's disease, the ferritin is significantly high. But remember that the ferritin can also be high in any state of inflammation because it's an inflammatory marker. So high ferritin does not necessarily make a diagnosis or confirm a diagnosis of Still's disease. In fact, Still's disease is a diagnosis of exclusion. It is a diagnosis of exclusion. You need to exclude everything else. And this is a very famous question at the exam. A high ferritin does not confirm a diagnosis of Still's disease. Remember that. Okay. Yeah. So you do those things, get sputums off, get x-rays off, get the CT done. If there are lymph nodes, biopsy those lymph nodes and get a HIV test off. Amir, I assume that this guy's HIV test was negative?
Yes, sir. It was negative.
Yeah. And the HRCT showed a possible sort of miliary thing.
Yes, sir. It says multiple tiny centrilobular and peribronchial small nodules scattered all over the both lung fields, favor of miliary TB.
Yeah, so it could be miliary TB. Fine. So that's what you would be asked. And for most of you guys, the discussion would probably end there. It would probably end there because remember, you only have a very short period of time for your discussion. So at the moment, it's 20 minutes, and you take about sort of 10 minutes to present the history and examination. The rest of the 10 minutes would be definition of PUO, a summary presentation, what is your differential diagnosis, and why, rationalize it, a little bit of questioning around that. And then finally, they would ask you, how would you investigate to confirm the diagnosis? That would be your discussion. And don't get worried They didn't ask me anything about the management and cry in your whatever room and come back and cry. No. This sort of case, I would just ask you investigate. I would not even touch or encroach on the management at all. So don't get worried. They didn't ask me to a management and I'm going to fail and that sort of rubbish. Don't worry about that. Yeah. Okay. Now, in some of you, they would ask you, right, fine, this guy has come back with fever. Why do you think this guy has fever again? And that would be a question that you would get asked in this patient as well. Now, this guy's come back with fever. Why do you think he has fever? Despite him having a good sort of response to anti-TB treatment. Well, you have to answer this question in a structured way. The first thing you would say is, right, the diagnosis might be wrong. We don't have a microbiological diagnosis of TB. We're just treating an HRCT which shows possible miliary TB. No organisms isolated. The cultures have been negative. So this could be a completely wrong diagnosis that we are doing, that we're treating as TB, right? And I've seen this. All of you read about Pill-Ebstein fever. Some people believe it's a myth, but just read about it. And you sometimes see patients with lymphoma, they have fever, and then they have a fever, long fever-free period, and then the fever comes back again, right? And that is due to lymphoma. That's a fever pattern which is described in lymphoma. So it could be a completely wrong diagnosis that we are dealing with here, right? So that could be the reason. So that's the first thing you say. It could be a completely wrong diagnosis. The second thing you say, this still could be TB, right? Still could be TB, but it might be a drug-resistant TB. Who knows, right? Usually in Sri Lanka, we don't see a lot of community-based drug resistance, but it's increasing in pockets. There are pockets. So could this be drug-resistant TB? The other common thing is, could this fever be a reaction to the anti-TB treatment? And that's something that we see very, very frequently in practice. Could this fever be a reaction to anti-TB treatment? Okay, anti-TB treatment. So the first thing is wrong diagnosis. We're dealing with completely something else. Might be a lymphoma, and we need to rethink our diagnosis. The second thing, this is still TB, but this could be, for example, drug-resistant TB. It's not responding to anti-TB. It could be the fever could be a reaction to anti-TB medication, which is a very common thing. And another thing that you see is read about immune reconstitution syndrome. And sometimes what you do is when you sort of kill the bacteria, right, it triggers the dead bacteria trigger off an inflammatory response. Okay, the dead bacteria trigger off an inflammatory response, and it actually gets worse before it gets better, right? So sometimes you see that in TB, and there is an entity called immune reconstitution syndrome. Read about that and tell me. I'll ask you tomorrow what that is. Okay, immune reconstitution syndrome. Fine. So the second answer is this is still TB. It's not responding. Could this be drug resistance? Is the medication not right? Inadequate dosing, for example, which is frequently not the case. Could this be a reaction to the anti-TB medication? Could this be sort of a reaction to the dead bacteria that's causing fever, where it gets worse before it gets better? It could be any one of those. The third thing is, this is a completely different fever, it might be a hospital-acquired infection, for example. This guy has been in several hospitals over a period of months, and it's easy to pick up a hospital-acquired infection, a UTI, or a hospital-acquired pneumonia, for example. Okay, so could this be something like that? Okay, could this be a hospital-acquired infection, or could this be dengue, right, which is very common in the community? Could this be dengue, or yeah, something like that? So you see the way I structured my answer. I just didn't blurt out a list of differential diagnoses as to the explanation of the fever this time. I said, number one, could our diagnosis be wrong? And could this be a lymphoma, for example? Could this be an alternate diagnosis, for example? The next thing is, yes, this is TB, but it's not responding to medication. Could this be drug resistant? It's unusual for it to sort of come this early, but still could be. Is this a reaction to anti-TB? Is it an adverse effect of anti-TB treatment? Is it a sort of immune reaction to the dead bacteria, where the immune system starts attacking the dead bacteria? There's an inflammatory response. Could this be immune reconstitution, which is described in HIV patients? Read about that. So the diagnosis is TB, but there's something funny going on, right? The third thing we said was, yeah, this is something else. The fever is due to something else. Is it a UTI? Is it a chest infection? Is it a hospital-acquired infection? Very commonly, cannula site infections, and we give patients staph through the cannula. Could this be something like that, right? Could this be, yeah, hospital-acquired infection? We were interested in seeing patients hospital-acquired endocarditis through lines and things. So that's again possible. So UTIs, hospital-acquired pneumonia, line infections, very common when people have been in hospital for a long time. Right? So those are the things that you think of as a cause for his current febrile episode. Okay. So those are the questions that I would, if I was the examiner, ask in your long case if you presented this case, right? So just to recap, in the discussion, so Amila has presented a good history. It's a very good history. You would see the way he structured his timeline very beautifully, right? And then gave a very detailed, in-depth history and examination. Very nicely done. The summary needs more work, and don't use these terms like alcoholic, chronic alcoholic, and mild palo, and those sort of words. Stick to professional accepted medical terms when you're describing things. But all in all, he did excellently on that presentation. So as to, I think that yeah, මෙහෙම මෙඩිකල්ස් මම සිංහලෙන් කතා කරන්නේ මේ නැත්තර මෙහෙම මෙඩිකල්ස් වලට මේ ලෝකෙ ලබ්බක් බෑ. හරිද? They should actually listen to some of you guys presenting histories and examination. These final year medical students in Oxford, they don't even know how to present a history, for heaven's sake, right? So you are much better than them. Yeah, I will say that anywhere, right? Even to the professor of medicine in Oxford, I will say that you are much better and your clinical skills are much better. I don't know what these guys are doing. So fine. So right. So yes. So very well done. So then moving on, the questions. What is the definition of PUO? Describe the base categories of PUO, and sort of talk about the causes. What is your differential diagnosis for this patient with PUO, loss of appetite, loss of weight, and hepatosplenomegaly? 3 top things: disseminated TB, lymphoma, and finally HIV, and then obviously mediosis and autoimmune things and other things. If you are really pressed for a list of differential diagnoses, how you would investigate the patient, the basic set of investigations, the specific investigation you do for HIV, specific investigation you do for TB, specific investigation you do for lymphoma, right? And then what would you do, and so on, right? And then the last question, he's come with fever again. Why do you think he has fever again? A structured way of answering that question. First, talking about, could it be an alternate diagnosis? Is it TB and just a reaction to anti-TB, or is it drug resistance, or is it IRS? Then could it be another infection like dengue or hospital-acquired infection like UTI, chest infection, or line infection? Yeah. Yeah, so that's basically it. I wouldn't ask anything else from this long case at all. Yeah, so that's all that you would ask. And any examiner, I think, would ask these questions only, nothing else, right? Okay, obviously you might get stuck in the middle of people asking about what, if you say chronic alcoholic to Panduka Karunanayak, he'll just rip you apart for saying that. And the whole discussion is going to be on alcohol, and you don't want to get into that situation. So don't use those sort of words. The other thing he hates is sexual promiscuity. Don't use that word with Panduka Karunanayak. He gets really wild about that as well. Fine. I hope that is it. Amila, could you just tell me what the thought process is currently, and what the ward staff, the consultants, think as to what's going on? I don't know anything about this case. I've just given a sort of discussion as to what you presented.
Yes, sir. They are also thinking about the possibility of lymphoma.
Yeah.
And trying to do a CECT abdomen, pelvis, and chest. Also, hematological referral for bone marrow biopsy.
Yes. It sounds all reasonable. Yeah. Okay.
And he's having thrombocytopenia currently. So it is, they think about due to anti-TB drugs.
I hope you sent off a dengue and things as well, just to be safe with thrombocytopenia.
Yes, sir. Dengue NS1 was done. It was negative, sir.
Was that within the proper time period?
Not proper time period. He presented after 5 days.
Yeah. So have they sent an antibody as well, or are they not worried about dengue? Probably it's not. Is it a high fever or is it just a low grade fever?
In the hospitals only high fever, several
Hmm.
spikes.
Right. Okay. So that's reasonable. Anything else that you're thinking of, or the ward is thinking of? Is Pandukas has seen this patient?
Uh, we only 2 days, sir. Chance only sees.
Yes. What does Chang think about it? So lymphoma, yes, which is very, very reasonable as a thought process.
And also hematological malignancy also.
Yeah, so that's a non-specific term, isn't it? Hematological malignancy. Right. Okay. Another thing that you might be able to do is, if the patient has a CT chest with all these lesions, a bronchoscopy might be quite useful for a microbiological diagnosis. So if this lymphoma thing ends up becoming negative and the CT abdomen doesn't show anything, bronchoscopy with sort of bronchoalveolar lavage will be quite useful to make the diagnosis of a microbiological diagnosis. You can send that off for various things as well. And has anybody an autoimmune thing, ANA, those things? I don't think that would be indicated, but have they done that?
No, sir, they have.
No. Yeah, that's fine. I think lymphoma should be top of the list. And you continue the anti-TB as well?
Yes, so they are continuing.
What do the chest physicians think about this?
They haven't referral was done, so
They should have. I don't know. That's fine. Okay. Right. So that's fine. So CT, abdomen, chest, abdomen, pelvis, and a bone marrow sounds quite reasonable. Okay. Yes, that's a beautiful long case of pyrexia of unknown origin. An excellent discussion. Few questions, but we've covered all the bases. So I need you to read now about PUO. Any questions? Right. How many people are there in your group, Hiru?
46, sir.
Yeah. So what's happened to the rest of the 5? Please find out what they're doing.
Okay, sir, sure.
Because I will not have time to do long cases just before your exam. So this is going to be it. So
Yes, sir.
make sure everybody attends. The timing is okay. So you can just, you finish at 4, don't you?
Yes, sir. We finish at 4, but the problem is there's a ETU and MISU shift for 6 students each day. I think.
And that goes on till?
8 o'clock.
Right. So that might be the problem then. Yeah, but
we can shift the class to 4 o'clock if I think it's possible, sir.
No, you have to find out what's better. Now the dicey thing at 4 o'clock is it's 11:30 for me. So
Okay.
If I'm doing ward rounds, that's going to be a bit difficult. This time is very good for me because it's basically after work and nobody's around the office and I can scream and shout whatever I like to do. Yeah, and interestingly, if I do it, yeah, it becomes a bit of a spectacle, and people start gathering around and listening as well. So it becomes a bit of a ad එකක් වගේ වෙනවා මෙතන මේ දවල් වරු කරනකොට.
Then
This is a good time.
9 p.m. is okay, sir. I asked from all the students, they are okay with it.
And basically, you can come 4, have a nap, and then wake up at 9. Anyway, you're studying, should be studying in the night. So, yeah, it's a generally okay time. I used to fall asleep. So, I would prefer to have it at this time unless it's a major problem. Then, of course, we can sort of do it. The problem 12:30 sort of my time. That will be about 5. But the problem is that මේක bucket set වෙනවා මචං. මේ එතකොට මේ ඔය board round එක දිග් ගැස්සෙනවා then සමහරවිට postpone කරලා ඒක වාතයක් වෙනවා. So this time I'm generally sure that I can do it every day. So ඔය දවල් බරුවේ මෙහෙ කරනකොට ටිකක් කචල් එක මේ නර්ස්ලා කතා කරලා එක බයිලා අහනවයි එක මිනිස්සු ඇඳවල් වලින් වැටෙනවයි ඔය වගේ වාත set වෙනවා දවල් බරුවේ. So yeah, prefer to have it at this time, but we can change. And just also here to ask the people if this is okay. So I'm going to continue doing it like this because it's going to be a long case and I'm training you for the exam, which is not long away, mind you. So this is September. So it's probably going to be somewhere around December, January. So not a long time to go. So you need to do some pre-reading on the class that I've already done. on symptom analysis, what history to ask in a PU and that sort of thing. And there are recordings and presentations that I've done. So please listen to those and bring yourself up to date. Yeah. Okay.
Okay, sir.
Right. For tomorrow, what are we going to do? You had sent me a list. That shortness of breath. What is that? Is there a diagnosis for that?
Shortness of breath. There's a patient with AF presenting with acute left ventricular failure, sir.
That's acute. Do you have a chronic
Yes,
sort of progressive shortness of breath? Sort of patient?
Progressive shortness of breath also there, sir, I think.
Yeah, let's try to do that.
Okay, sir.
So it's preferably something like chronic heart failure or interstitial lung disease or anemia or something like that. If we fail to find any of those, we'll do the liver one. There was a liver patient, wasn't there? With
yes, sir. Liver patient was there. Yeah.
Yeah. So we'll do that. If we fail to find a shortness of breath, see if you can. Yeah.
Okay, sir. I'll find.
Right. Okay then. Any questions? Ari. Okay, then see you tomorrow.
Okay, sir. Thank you so much.
No problem.
Thank you, sir.
Thank you, sir.
Okay.
Thank you very much, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Problem.